Can we start now, Yogendra?
Just a moment, ma'am. Just a moment.
Yeah, one second.
So good evening, everyone. This is Feroz Khan from Walter Bushnell Marketing Team. And on behalf of Walter Bushnell, we welcome you to this wonderful webinar on the theme World Hypertension Day. This is conducted under the aegis of AMOX and AMOX Public Welfare, Public Awareness Committee and High Risk Pregnancy Committee. So without any further delay, can we have this inauguration slide, Yogendra? So now I would like to call upon Dr. Pratibha Baldava, ma'am. Can we have her CV, please?
Good evening, all.
Just a sec, ma'am. So Dr. Pratibha Baldava, ma'am, is the consultant Obs and Gynae at SS Baldava Neurosciences and Women Care Hospital, Solapur. Ma'am is a gold medalist as DFP Fellow of American College of Obstetrics and Gynecology. She was the Treasurer and Honorary Secretary of SOGS during the year 17-18 and 18-19. Currently, she is the Executive Member of SOGS 21-23. Under her name, 12 national papers that are being published in various renowned journals, along with the one international paper on successful fetal outcome in 95 COVID-positive pregnant women in January 22. So over to you, Pratibha, ma'am.
Yes.
Thank you, ma'am.
Thank you so much. Today we have all gathered for a webinar on World Hypertension Day. World Hypertension Day is to communicate to the public the importance of hypertension and its serious medical complications. It is the purpose for prevention, detection and treatment of hypertension. Preeclampsia in India is still very prevalent and is a major cause of maternal morbidity and mortality. So I'm very happy today that we're discussing this, and the salient points discussed today will help us to prevent the complications of preeclampsia, and we will thereby be able to decrease the maternal morbidity and mortality. I would like this webinar is being conducted under the aegis of AMOX by the PAC committee, that is the Public Awareness Committee, whose chairperson is Dr. Monica Umbardan, and the High Risk Prevention Committee, whose chairperson is Dr. Rashmi Kahar. So I welcome Dr. Monica Umbardan to please carry on the session. Dr. Monica Umbardan.
Pratibha, let it be.
Okay, this is a...
Yes. Thank you, Pratibha. I welcome all the esteemed faculties, Pardeshi sir, Sujata ma'am, Girija ma'am and Chavala madam for joining us in this initiative for the World Hypertension Day. We are having two lectures. First would be the screening and prevention of preeclampsia, and the second one is the surgical management of PTH. Both of these topics have been selected taking in view of the World Hypertension Day as well as the Safe Motherhood Month that we will be celebrating this April. That is why we have taken these two topics. Thank you so much for accepting our invitation and gracing this occasion. Pardeshi sir has been the mentor, and he's always been the guiding force behind all our webinars. Thank you so much, sir, for allowing us to carry out this under the AMOX banner. Pratibha, can we now introduce Pardeshi sir formally?
It's okay, Monica. It's okay, Monica. We can skip this. Good evening, everybody. Respected Dr. Sujata Dalvi, Dr. Monica Umbardan, Dr. Rashmi Kahar, Dr. Girija Wagh, Dr. Charmila Ayau. First, I wish to congratulate Dr. Monica Umbardan and Rashmi Kahar. Both are our ever active, ever smiling chairpersons and pillars of AMOGS for organizing such an academic and practical webinar on the eve of World Hypertensive Day. As all knows that hypertensive disorders contributes around 10 to 12% of causes of maternal mortality. Hence, to curb this, these types of webinars, CMEs, and public awareness programs will be very useful. And with the eminent faculties like Dr. Girija Wagh, Dr. Charmila Ayavu, this will be a great program. I appreciate these two faculties for their continuous efforts in the field of hypertensive disorders in pregnancy. Especially to Dr. Girija Wagh, I wish to mention, she has just finished a talk on hypertension in pregnancy at 4 p.m. in a webinar and joined here also. I don't know how many webinars she is attending today on the eve of World Hypertension Day. I congratulate again Dr. Monica and Dr. Rashmi with able conveners and MOC, Dr. Pratibha Baldava and Dr. Jaya Tuluskar for their excellent work for this webinar and for AMOG's work also. I wish every success to this event. Thank you. Thank you so much for inviting me. Thank you.
Thank you so much for gracing the occasion, sir, and your blessings. Pratibha, now we can have Sujata Madam's slide.
I think we can skip the intro. We'll just start off with this. Yeah. Monica, we can skip the intro. We'll start.
Sure, ma'am.
Yeah, okay. So at the outset, as the Secretary of AMOGS, I would like to express gratitude to our President AMOGS, Dr. Rajendra Singh Pardesi, for always encouraging some sort of a scientific session as such. I would also like to express my gratitude to AMOGS Public Awareness Committee Chairperson, Dr. Monica Umberdan, and High Risk Pregnancy Committee Chairperson, Dr. Rashmi Kahar, for holding such a webinar on a World Hypertensive Day. We have a very expert speaker, Dr. Girija Wagh, who is going to speak on pregnant preeclampsia, and Dr. Charmila, who is going to speak on surgical management of PPH. Both these topics are important so as to reduce the maternal mortality as well as morbidity. And I'm sure it will give a very good message to all those who have logged in so that they will be able to implement in their practice. I would also like to acknowledge the efforts as a master of ceremony for today's program, and my best wishes for today's program. Thank you so much.
Thank you, ma'am. Thank you so much for your blessings. Now, it is an honor to have both of you here, ma'am. Thank you so much. We now move forward with the scientific session. Pratibha, can you introduce Dr. Girija Wagh, ma'am, now?
Yes. Firoz, please, I want Girija ma'am's slide.
Sure, ma'am.
Dr. Girija ma'am. Dr. Girija Wagh is a very well-known personality. She is a professor and HOD Department of OBGYN at Bharati Vidyapeeth Hospital.
I think we can just skip it, my dear.
And she has given us so many educational lectures. We have listened to her so many times. We are really eager to listen to you, madam.
Thank you so much.
Please.
Thanks.
Yeah.
Can I have the permission to present? Yeah, share my slide. Yes.
Right, ma'am. Right.
So thank you, AMOGS. It's always a pleasure to be on your home turf. And I hope you are able to see my presentation. Are you able to see my presentation?
Yes, ma'am.
So we are speaking about clinical risk assessment and management and prevention of preeclampsia. That is our task today. And we must remember that whenever you have a blood pressure rise or symptoms such as excessive weight gain, maternal risk factors, swelling, edema, feeling of being unwell, these are all tip of the iceberg, which are going to show you so many things under that, which requires, so this your clinical risk itself can be assessed by being a little patient and assessing your patients, looking at her history and seeing her entire tenure, and you can see that these are the maladies which can happen to these patients, which can be definitely avoided, like getting into an ICU and suffering from eclampsia, which are definitely health rendering. There is an imbalance between placental dysfunction and systemic vasoconstriction, which we all know, which causes multisystemic affection of the woman. And therefore, we as clinicians require to fall in some place somewhere where we'll be able to stop this conglomerate of abnormalities. Now, before the clinical disease comes, there are a lot of things which are happening in the woman's body when during the stage 1 of the disorder, such as the immunological factors, the environmental factors, the placental, apoptotic factors, which can help us in trying to diagnose these conditions. And therefore, many times we are looking at other kind of biochemical markers or any sonographic clues which can help us in identifying this condition. Now, over a long period of time from 2009 till now, there has been a proposition made for various such factors. And many a times we realize that all these guidelines make their guidelines, but these are out of reach for us and our patients. And therefore, in 2019, 2020, some around, Justosis came up with its Justosis score, which is a very clinical, simple risk assessment score, which can help us to identify these things. Much came into foray with the publication of the SPREE study. And in this SPREE study, what it mentioned was, you have to take everything under the factor everything. Maternal factors, uterine RTPI, PLGF versus MF, uterine RTPI, PLGF, and MAP was done. And it was found that if you take all these things together, your risk assessment would be much better. But then we felt in the Justosis score, doesn't matter. Let's look at the maternal risk factors, the uterine RTPI. If it even tells us that it is sensitive by 40 to 60%, much more better effects we will be able to do. And then came the ASPRE study, which said that you can give aspirin and that can help you in reducing the risk. Now, over a period of time, a lot of publications Leona Poole's group has been doing on the same subject that they have studied about the various factors, trying to find out whether early onset preeclampsia can be diagnosed better by looking at the screening. And we all helplessly look at it as Indians because many times our patients may not come to us in the time, or many times we are not able to afford these particular tests which have been mentioned in all these screening. So if you look at all the types of screenings that have been mentioned in the first trimester, the second trimester, and the risk evaluation, we felt in the first trimester itself, we can place the Justosis score, segregate the mother as a low-risk mother and a high-risk mother, and then specifically apply these screening technologies or methodologies, or maybe just give her a close clinical surveillance, and that would help us in reducing the maternal morbidity and the mortality. Now, simple things such as blood pressure, mean arterial pressure, proteinuria, and if necessary, the biochemical tests and uterine RTPI, which most of us have an access to, can be done. What is very important in clinical risk assessment is that you have to measure the blood pressure correctly, because the patient has to use the correct cuff. She should be in the sitting position. The arm has to be at the level of the heart, and you must preferably use a mercury sphygmomanometer. If that is not available, a calibrated aneroid machine can be done, or you can use a mean arterial pressure. Apply the risk calculator, which is freely available online, and calculate the risk of your patients. It was found that just measuring blood pressure correctly, looking at the priori risk, will do a lot of good in trying to treat these patients correctly. Another thing is doing screening for urinary proteinuria. A simple dipstick can be better. But if you have risk factors on one side, the proteins have come negative, you can do a spot test in the form of an protein creatinine ratio. And if it is more than 30 milligrams per millimoles in a singleton pregnancy, it would be significant. In a twin, 40 is taken as a cutoff. And then you may not do the 24-hour urinary protein, which we have been doing as a gold standard for so many days. Whenever the patient has blood pressure, do not forget to do her laboratory tests, because we will want to know whether she has leukocytosis, thrombocytopenia, hemoconcentration by doing the CBC. Then look at the liver function test, the coagulation profile, and now LDH, which we were talking about 12 years back, has been included in the ACOG practice bulletin of 2020, which helps us in understanding systemic hemolysis and can help us take care of our patients better. Now, with lot of technological understanding and research today, we have come to understand certain biomarkers which can be applied in various trimesters, PLGF, PAPE, and endocrine. In the first trimester itself, at the time of combined testing, you may add PLGF to help you segregate the high-risk mothers. And if you have a patient who is showing blood pressure problems, who is showing proteinuria, you want to know how long can I wait on this patient, you may consider doing a PLGF, S-plate PLGF ratio, or glycosylated fibronectin, or HS troponin I, which I'm going to talk to also about. Uterine artery pulsatility index done at 11 to 13 or 6 weeks of gestation. Definitely, if you find that the uterine PI is more than the 95th percentile for that gestational age, it is a hallmark which can help us in trying to give them a good continuum of care. And you must be aware of this particular check, which will help us in correctly advising treatments to this patient. You must know the values in each trimester. First trimester, 2.35 on a transabdominal scan, 3.10 on a transvaginal scan. Second trimester, 1.44 and 1.58 respectively. And in the third trimester, we will not do a TVS. Usually it will be the transabdominal 1.17. And these are the uterine artery PI cutoff values, which tell us that, okay, there is now a resistance in the placental bed, start doing closer surveillance. In the first trimester screening, if it comes positive for preeclampsia, it is very, very highly predictive, and you can consider using 150 milligrams of aspirin. Continue it till 36 weeks of gestation because you also want to cover the late onset preeclampsia. The ISSP recommends 150 milligrams also, as does the FIGO. And the ISSP additionally says give calcium, especially in countries like us where the calcium deficiency is very prevalent, because our women consume less than 600 milligram of calcium per day. And this two-stage screening in low resource setup is a very, very wonderful thing, like the Justice score followed by a surveillance. Now, NICE guidelines and the ACOG guidelines are very well known and spoken about. And in the ACOG 2020, they also included women who had undergone artificial reproductive technique. And you can see a very busy slide here. NICE, SOGC, SOMANS, ISSP, all have various guidelines. And then we realized that in our country, we have a little different phenotype. And therefore, we did a lot of head breaking, head scratching, and came up with this Justice score, where we took into account the adolescent women, the PCOD, the hypothyroidism, the weight gain was factored, and other factors which were given a segregated score. So this is feasible based on history and MAP, cost effective. And if the score is more than 3, we consider it as a high-risk mother with a closer surveillance. Now, anemia is a very simple thing. None of these guidelines mention, but in our guideline, we talk of anemia because we know that if there is complements which are created because of abnormal reactions of the mother to the baby, then these complements are taken away by erythrocyte complement receptor type 1, which are sitting on the RBCs. In anemic patients, they will be deficient. And typically, therefore, we see anemia is associated with preeclampsia in our country. And therefore, that can be one important start-off point that if you correct anemia, you'll be able to reduce this. Obesity, our obesity is different. We have a lot of dyslipidemia, and we have obesity occurring even from a younger age group. And that also is one of the important risk factors. Nulli-gravity also has been identified to have higher circulating S-plate 1 and S-plate PLGF ratios. Likewise, a family history of preeclampsia or hypertension has been identified to be important. Polycystic ovarian syndrome has become a typical Asian Indian condition, and hyperandrogenicity and insulin resistance are known to be risk factors. Likewise, currently, with greater socio-economical improvement, we are finding women are planning pregnancies after the second pregnancy or much later. So if the interval is found to be more than 6 to 7 hours, 7 years, that primary sensitization and protection she received with her first pregnancy does not last, and this also has to be factored. ART, IVF pregnancies, azoospermic, oligospermic, or donor oocytes, if they have been taken, are associated with severe early onset preeclampsia. Thus also thyroid hypofunction, dysfunction, thyroiditis are known to be associated. If you have a woman who has GDM, you must screen her, and we know that there is 1.5-fold increase risk overall. Likewise, in multiple gestation pregnancies, it's found that it definitely causes problems, not only because sometimes it can be an ART pregnancy commonly, there can be oocyte donation, and there can be other issues where S-FLET-L1 and S-FLET-PLGF ratios are always high. Thrombophilia, autoimmune disorders. So all these things can be just looked through in the history. And friends, one more issue about mental health like bipolar disorder or schizophrenia. These women have 5-fold increased likelihood of having preeclampsia, and one study also found 5 to 3-fold increase is possible. In our university hospital, we were blessed with an ICMR Center of Advanced Research kind of a category where we published this revamped study. And this study was started in 2017, was given a duration of 5 years, and we are now doing a lot of publication based on this cohort, where women with preeclampsia were found to be older professionals and educated nullipara. They had conceived by ART most of the times. Higher BMI, systolic blood pressure in preeclampsia was found to be there in all point of times which were taken during the pregnancy, and higher percent of women in PE group delivered by C-section. And what was very important, TSH levels, if they are higher at 11 to 14 weeks and 26 to 28 weeks, preeclampsia was quite common. So the rationale of Gestosis score was based on this particular factor, that even if you look at the risk factor, it will give you an answer like the Schoner et al. Score, where you look at top 10 risk factors and then segregate this particular population to identify whether there is risk of coronary heart disease. Every time a woman comes to you for an antenatal visit, do a careful clinical investigation, evaluation. At early visit, ongoing surveillance has to be there. Every time you must ask her pertinent questions about visual disturbances, headache, epigastric pain, sudden onset or rapidly progressing pedal edema or generalized edema. Do a correct examination, look for edema, try to look for any other telltale signs of severity such as headache, vomiting, breathlessness, blurring of vision. Sometimes they don't tell you these answers. We have had patients not telling you anything, just showing us sonography report, going home, and then coming back in the middle of the night with a convulsion stroke or an HELLP syndrome. So signs in preeclampsia have to be correctly emitted. If you have a woman of chronic hypertension, do a fundoscopy in this woman, because we can look at retinal vasospasm, and always do a per abdominal palpation. If you have a chronic hypertension, request your sonologist, if you are not doing sonography, to look at the liver surface. So whenever you have patients who are less than 20 weeks, more than 20 weeks, accordingly, you must define, categorize which kind of hypertension if she presents with, and do a proper clinical risk assessment. Because we have to remember that even if a woman has white coat hypertension, she has 8% risk of developing preeclampsia, transient hypertension 20%, gestational hypertension 25%, and chronic hypertension 25%. If your patient has proteinuric hypertension, admit her, examine her. If her blood pressure is high, start her on antihypertensive medicines as advised by the CHIP study, so that you can reduce the complications and prevent them, and then you can consider the triaging of her later. It's very, very important to do the lab test as the ISSP guidelines and even the FOXY ICOG guidelines say, and do the risk stratification at every point of time. Now, if you are worried about prognosis, PLGF and S-FLET ratio can help you in segregating in those patients who require immediate delivery or who can be given expected management. And we have now recently in 2022 publication of the CHAP study, which says that every hypertension in pregnancy has to be treated for maternal benefits. Now, if you look at the PARROT study, which was talking about PLGF to be used as a segregating factor, it has been found that if you find the PLGF is less than 20 picograms per ml, then that is definitely going to tell you that this is a high-risk mother requiring closer surveillance and probably a delivery. And that is something that one has to remember that PLGF less than 12 is a very low PLGF, more than 12 and less than 100 is low. There can be step-up care. If it is more than 100, then that is normal, and you can then wait on that patient and give her some time. So this is the placental growth factor, which tells us, and the CHAP study, which I already spoke to you about. Additionally, in these women, even any pregnant women for that matter, I do universally, whether she has any of the risk factors under justosis score, it's always a good practice to do their maternal echo, because that will help us in identifying diastolic dysfunction and left ventricular remodeling, which are the key features of heart being involved in these patients. And then we can definitely prevent a lot of complications. And this has been spoken in this systematic review, wherein you can use doing echo as a standard screening protocol for preventing abnormal outcomes in women with hypertension of any category. Do your fetal surveillance properly, and definitely remember the algorithm of the diagnosis, the Doppler assessments, because you must deliver your babies right on time, not very premature, not very sick, and not very morbid. So that balance is important, because whenever you have a reverse end diastolic flow, you must remember that more than 70% of the intervallar circulation is compromised. And now it is time to deliver these patients by cesarean section. And ductus venosus or umbilical vein involvement tells you about fetal acidemia, which has a very poor prognosis. And CPR can help you, that is cerebroplacental ratio of more than 1, can give you some time, but you have to always tailor make your decisions for these patients, because CPR ratios sometimes in patients of preeclampsia may not be properly interpreted. This was the cascade of the Doppler management that I was telling. We are not going to dwell with it much more. What we are going to learn about is Phoenix trial, which has said that there's a strong evidence to suggest that planned delivery reduces maternal morbidity and severe hypertension compared with expected management, with more neonatal unit admissions related to prematurity, but no indicators of greater neonatal morbidity. So take your judicious decisions. That's what the Phoenix trial says. And never forget to put your women under close postpartum surveillance, educate them. They'll come to you back when there are early warning signs or at the end of 15 days. And then you're going to continue your antihypertensives. You're going to tell them to come to you again after a period of 6 weeks, and then guide them about their future lifestyle and future pregnancy planning. Now, many times we are unable to do the various kinds of S-FLAG PLGF ratios. So for low middle income countries, there are certain scores which have been recommended. And the FIGO says, don't do all these very things. You can just do a clinical assessment and a risk stratification. And therefore, we always speak about this, our own indigenous justosis score, a screening protocol, wherein you can score your patients and accordingly apply the advanced surveillance methods. Counsel them mothers, do the biochemical markers only in those severely high-risk mothers. Vigilant antenatal surveillance, where educating them, dietary supplements, regular BP checkup, be alert about GDM, hypothyroidism, excessive weight gain, and supportive treatments in the form of folic acid, calcium, vitamin D supplements, exercise, and anemia correction are important. Do a proper Doppler surveillance. And this was the HS troponin I, which was talking to you, wherein you can use this as a marker for early risk stratification, and also in those high-risk mothers, where you will understand that probably she is going to be suffering from cardiomyopathy. So this was the S-FLAG PLGF study, which was primarily studied by Rana et al., but now the Parrot study has shown that it can be used for proper risk stratification. Now, screening definitely has certain benefits of early awareness, prompt clinical interventions, reducing NICU unit admissions, and reducing future risks. But there are certain other also disadvantages, such as unnecessary anxiety, side effects of complications associated with therapeutic prophylaxis. And therefore, you can do prevention by pharmacological drugs, dietary interventions, and modification of lifestyles. Aspirin has proved to be once again a very, very effective antiplatelet agent, and we have been using it in the dose of 75 milligrams daily from 12 weeks in high-risk patients. But the recent studies are showing that 150 milligrams brings you a better promise, but definitely ensure that your patients are compliant and you're giving it at night and they're taking it daily. Nitric oxide agents such as the GTM and the NO donors have not been found to be useful, and they show an insufficient evidence. LMWH, heparin, and others again show an insufficient evidence, along with progesterone and diuretics. Calcium is known to act by reducing the smooth muscle contractility and vasoconstriction, and is known to increase the magnesium levels. Reduce resistance in the uterine and the umbilical arteries is seen, and a daily recommended dose is 1.5 to 2 grams of calcium per day, and you must ensure that they are taking it from dietary sources. Antioxidants, folic acid, magnesium, marine oil, and other PG receptors unfortunately do not have any quality evidence to back up about their utility, but lifestyle interventions such as rest, 4 to 6 hours or 30 minutes per day, no evidence has been shown. Exercise is known to increase the plasma volume and the cardiac output, reduce plasma triglycerides, inflammatory cytokines, and insulin resistance, but there is no evidence to support again. But I'm going to show you one study which has supported recently. Dietary salt intake has now been told by the CHAP study. Energy and protein intake, and garlic has no evidence. Now you can see this malady of a woman. She's just about 21 years preemie, delivered at 26 weeks, picture after 2 days of delivery, excessive edema, has ascites, and she's drowning in her own waters. Typically protein energy malnutrition, kwashiorkor-like picture, which really makes tears come to your eyes. And therefore, I always believe in this protein theory, where you must ensure that women are taking adequate proteins in your diet so that they will not have edema. If they have a good volume flowing in their blood vessels, their adrenals will not get activated to cause rise in blood pressure. So ensure, as the FIGO says, 1 gram per kg body weight of protein from the start of the pregnancy till the end of the pregnancy, which can definitely reduce such kind of an occurrence. And this was the study I was talking to you by Laura Meggie, published in NEJM 2022, recommending moderate exercise of more than 140 minutes per week reduces 40% of preeclampsia. High risk of preeclampsia, initiate aspirin more than 100 milligrams per day. Before 16 weeks, 60% reduction. Dietary calcium intake, 50% reduction, and time birth, 35% reduction in preeclampsia after 39 weeks of gestation. So we are here, friends, currently. Prior to pregnancy, you can do preconceptional counseling and preparation for conception, correct their anemia, obesity, chronic hypertension, hypothyroidism, PCOS, diabetes. Primary prevention by proper assessment throughout the pregnancy, and if necessary, doing all these tests and giving them calcium supplementations. And antioxidants, the spree, aspirate, triple test FMF, and gestosis scores can be applied here. Once you have hypertension setting in, start the hypertensive management, even if it is 140/90, which will reduce a lot of maternal complications, as says the CHIP study, and then deliver these patients on time as per the Phoenix study. So in conclusion, generally low sensitivities of the tests evaluated refrain from testing, initiate preventive measures, aspirin at 12 weeks in high and moderate risk factors, calcium intake in low calcium intake. Don't advise LMWH, progesterone, NO donors, antihypertensives, diuretics, or antioxidants unnecessarily without doing dietary advice analysis, and lifestyle changes is my personal preference for these women. Thank you for giving me this opportunity, friends. And I want to thank you all once again, because it was only with your love and support that I am now the Vice President Foxy elect. Thank you for giving me this stage. I hope I have been able to deliver to what you were expecting of me. Hello?
Hello, ma'am.
Yeah?
Yes, ma'am.
Pratibha, ma'am. Hello.
Jaya ma'am is also there.
Yes, ma'am.
Thank you very much, madam, for that
Yes, ma'am.
informative talk on preeclampsia. We were really awed by the information, and really there are preventive techniques how we can bring down the preeclampsia and also decrease the maternal morbidity and mortality. Thank you so much, Girija ma'am. And now we move on to the next lecture, Surgical Management of PPH by Dr. Charmila Ayu. Charmila Ayu madam is traveling and so she cannot join us live. She will be, so we have a video recording of her, we'll play the same. Can I have Charmila Ayu madam CD please? Sharmila Ayu madam is Vice President-elect FOXY 2024, Chairperson for Clinical Research Committee, National Coordinator for UNICEF, FOXY PCA, and past Secretary of Trichy, President Menstrual Hygiene Management Committee, and Joint Secretary of Justices India Association. Now we'll listen to her video recording.
योगेंद्र मैं शेयर करता हूँ. लेट्स सी मेरा वर्क करता है प्रॉपर क्या.
Right,
आपका
right,
फिर
sir.
ट्राई
Yeah, we can play the
Good evening to all. Thank you so much, Dr. Monica, for the opportunity. I will just start my
the
talk.
audio is not with audio is not coming.
Extremely sorry that I am sending a
Yeah.
recorded video, but I may not be able to join because I'll be traveling at that point of time. Thank you so much, Dr. Monica. This talk is basically on the surgical management of PPH. And we need to know that we actually, most of us understand that it's a minor bleeding post-delivery if it is around 500 ml. And usually that should be within 24 hours of the birth of the baby. It can be a major hemorrhage when it's more than 1000 ml. And there's a classification according to Royal College where they divided it into moderate and severe also. Moderate is 1000 to 2000 ml of loss after a delivery, or it becomes very severe if it's more than 2000 ml loss. But actually, what is PPHS? It's not only the loss per se, it is also, we have to consider that if there's a need for a transfusion, then we have to consider that as a postpartum hemorrhage, even though it may not be to that limit which they've classified as 500 or 1000 ml. And if there's a 10% drop in hemoglobin post-delivery, that also means that you've lost blood after the delivery. But the practical point is any amount of blood loss after delivery, which is altering the patient's vitals, like the pulse, blood pressure, and respiration, then that should be considered as postpartum hemorrhage. And for identification of the severity of the hemorrhage, more than the visual estimation, which is quite inaccurate, we have to see for the clinical signs and symptoms, which needs to be always included in the assessment of PPH, because you should not miss what is being changing in the patient's parameters. And this is the physiological response to bleeding, which happens, which we always have to remember, because we tend to like overlook all these findings when the patient is having a hemorrhage. So it's class 1 if she's lost 1000 ml of blood, and that is almost like 15% of her blood volume. The patient will be manifesting at that point of time with dizziness, palpitation, and some minimal BP changes. So do not rely on the BP thinking it's normal. The second is class 2 hemorrhage, and that is a 1.5 liter loss, and that is almost equal to 20 to 25% of the total blood volume of the patient. Now she'll be having tachycardia, tachypnea, sweating, weakness, and a narrowed pulse pressure. It becomes class 3 if she's having significant tachycardia of almost 120 to 160, significant tachypnea of more than 30 actually, restlessness, pallor, cool extremities, and that means she has lost almost 2 liters of blood, and that is 30 to 35% of her total volume. When she crosses a loss of 2.5 liters, that's almost like 40% of her blood volume. You will be seeing the patient having shock, air hunger, oliguria, or anuria. Whom should you call when there's a postpartum hemorrhage? If it's a minor hemorrhage, actually it can be managed at the resident level. But if there's a loss which is more than 1000 ml, that's if it's a severe major PPH, it should involve a senior member of the staff, because there may be ongoing and regarding resuscitation for minor PPH without a clinical shock, IV access with a 14 gauge cannula is needed. and a urgent venipuncture for blood being sent for grouping and screening, a full blood count, and a coagulation screening, including fibrinogen, should be given even before the bleeding becomes more, because you need to know what's happening to the coagulation profile. And the patient's pulse, respiratory rate, and blood pressure should be recorded every 15 minutes. And you should start commencing warmed crystalloids when the patient is in minor PPH without shock. Do not stinge on the crystalloids. You need to give them because you will not even know that she's losing. But any indication of minor PPH, you should start on crystalloids. For major PPH, it becomes the CAB. You have to evaluate the circulation, have to assess the airway and breathing for the patient, position her flat, keep her warm using appropriate available measures, transfuse blood as soon as possible if it's clinically required. Until the time blood is available, infuse almost 3.5 liters of warmed clear fluids, and at least initially a 2 liter of crystalloid, 2 liters of crystalloid, which should be warmed isotonic. Do not give your IV fluids through special blood filters because they will slow down the intravenous fluid infusions. So blood should be only for blood. And if medical methods fail in atonic PPH, if you're given all your uterotonics possible, do not wait for the drugs to act if they are not acting at that point of time. Do not wait for a longer period of time. Please resort to surgical methods much earlier. And if you suspect a trauma as a reason for the postpartum hemorrhage, then exploration is mandatory. And you can always use an ultrasound to aid the diagnosis of why she's bleeding postpartum. Regarding the first surgical measure which should be done is the intrauterine balloon tamponade. It can be used after a vaginal or a cesarean birth to stop the bleeding from the uterine cavity. The balloon is filled up to its capacity until the time it stops the bleeding, and a continued excessive bleeding after you put the balloon indicates that the tamponade is not effective. So go on to the next measure. Do not think that the balloon will work later on. If it's not working at that point of time when you fill the uterine cavity, then it's not working at all. So the surgical methods other than balloon tamponade for atonic PPH, the first are the compression sutures, second is stepwise devascularization, and the third is hysterectomy. And the incision for a surgical management following vaginal birth, go for a midline laparotomy incision, and that provides the best exposure of both the pelvis and the abdomen for assessment and treatment of suspected pelvic bleeding. But if she has undergone a cesarean section, the existing incision can be used and can be extended laterally if needed to provide adequate exposure. Compression sutures are effective in atonic PPH are Heyman sutures, Cho sutures, and the sandwich technique. The B-line suture is the most common technique which I've been using for uterine compression in a PPH, in atonic PPH. But there may be some complications like uterine necrosis, erosion, pyometra, but they're quite rare. The limited follow-up which has been done for post suturing of for atonic PPH has shown that there's no adverse effects of fertility or a future pregnancy outcome. But remember, it will not control hemorrhage from placenta preta spectrum. So do not put a compression suture in placenta preta, and it will not prevent PPH in future pregnancy. She may still land up in PPH in the next pregnancy also. The B-Lynch suture is done with one or two, there is a thick chromic catgut. You put on a large Mayo needle, and it's used to enter and exit the uterine cavity laterally in the lower uterine segment. The large suture is used so that there's no breakage of the suture when you're using it. And the rapid absorption which can be there with chromic catgut will prevent the herniation of bubble through suture loop if the suture is a long-acting suture. And that's why you use a short, the ones which are absorbed quite easily. The suture the anterior lateral lower uterine segment opposite and parallel to the initial bites. But once when you've taken the suture, remember to compress the uterus and then tie it tightly, because if you tie it on a lax uterus, it's not useful at all. The next suture, which is much easier than the B-Lynch, is the Heyman sutures, where you take 2 to 4 vertical compression sutures from the anterior and posterior wall. You don't need a hysterotomy incision. Suppose she's delivered vaginally, you need not go and open and it becomes like a cesarean for her next pregnancy. But here you can just tie it and it will cause the compression, which is equal to the B-Lynch sutures. And you can also place a transverse cervicoisthmic suture, which will control bleeding from the lower uterine segment. So that's one advantage. In B-Lynch, you have both together. Here you can take the vertical sutures, and if it's not effective, then you can take a transverse suture also. The Pereira suture is one where you take through the myometrium also, the subserosal myometrium, without entering the uterine cavity. Here, a delayed absorbable multifilament suture is used. Two or three rows of these sutures are placed in each direction to completely envelop and compress the uterus. The longitudinal sutures will begin and they will then be tied to the transverse suture nearest to the cervix. So you actually like engulf the entire uterus so that you cause a compression. And here also you have to manually compress the uterus before you tie down the sutures to facilitate maximal compression. The toe sutures are ones which are taken as square sutures, multiple sutures over the whole body of the uterus, and use a straight 10 centimeter needle for this. This may be probably useful in placenta previa compared to the other types of sutures. Something called a uterine sandwich technique where you combine the balloon with the sutures. Here you insert B-length sutures, then you fill the balloon and fill it with 100 ml of fluid. Then you close the uterine incision, taking care not to burst the balloon. Then you tie the B-length once you fill the balloon with 100 ml of fluid. Then once you tie it, then you again inflate the balloon so that it fills up the entire uterine cavity. This seems to work much better in severe forms of atonic BPH. The next procedure after the uterine compression sutures is the stepwise uterine devascularization. Here, you successfully ligate one uterine artery, then the other uterine artery, then the lower uterine arteries which are going into the cervix. Then you ligate one ovarian artery and then the next ovarian arteries. There was one study which was done in 1994 where they, for 103 patients with intractable PPH, which is not responding to medical management, but they did this devascularization. They said it worked very well and none of them needed hysterectomy. So that was, they consider that as the first line conservative surgical treatment to control PPH more than the compression sutures. But now we find that the compression sutures are equally effective. If you want to combine the compression sutures and the stepwise devascularization, be careful because there's a higher risk of uterine ischemia, and that's because you combine it with vessel ligation, but there's no negative impact on fertility. But you can combine the B-Lynch or the hemostatic suturing with balloon tamponade, which does not cause these problems of uterine ischemia, but it's more common if you combine devascularization along with a compression suture. And when you want to evaluate for the source of bleeding, it's not atonic PPH. When you open up a laparotomy, if it's atonic, it's going to be quite visible there. Retained placental fragments may be the next reason for source of bleeding. Uterine lacerations may be a reason. Uterine incision may be a reason. That is, the uterine incision may be bleeding and it will be apparent in laparotomy, but sometimes it's not visible at all. Then you need to systematically check every part to find out where the bleeding happens. So it can be from inside the uterine cavity, which can happen after a vaginal birth or even after closure of the uterine incision at cesarean. It can be retroperitoneal hematoma, which will include the vaginal and vulvar hematomas from trauma to branch of the pudendal, uterine arteries or veins, and can be also due to a rupture of the posterior uterine wall. So remember to systematically check every part of the uterine cavity as well as outside and the retroperitoneum before you can identify the source of bleeding in certain cases. When there's an intra-abdominal bleeding without an obvious uterine rupture or bleeding vessel in the uterus, it may be because of a hepatic or splenic rupture or even a rupture of a visceral artery, aneurysm or pseudoaneurysm. So be extremely careful when you're going for a laparotomy to evaluate the source of bleeding. Be ready for anything. Yeah. And when the patient is hemodynamically unstable after a postpartum hemorrhage, you need to do some temporary measures to stabilize her before you go for surgical methods. You cannot just jump into surgical methods without stabilizing her. There are temporary maneuvers which can be attempted prior to performing surgical procedures. This will support the patient hemodynamically while the preparations are being done and can be quite life-saving. But the option which you choose to stabilize, which you need to follow to stabilize her before you open her up depends on the urgency to control the bleeding, the source of bleeding, which can be intrauterine or extrauterine, and the surgeon's expertise and preference is the main part in deciding which procedure you're going to do as a temporary maneuver before you attempt a surgical option. Suppose there's an imminent risk of exsanguination, the patient is very bad, and there's a chance that she's going to collapse in the next few minutes. The best technique to stop, to make her stable is a manual aortic compression, where you do procedures on the aorta to stop the bleeding from the bleeding vessel or from the uterus. You can do a manual aortic compression, or you can occlude the aorta with a balloon. You can go for a direct aortic approach or you can put an aortic clamp. Dr. Paley's clamp is quite useful for a person who's hemodynamically unstable. Regarding the manual aortic compression, you apply direct pressure to the aorta to compress it against the vertebra, and that you do a few centimeters superior to the sacral promontory. That is, a bifurcation of the common iliac artery is just distal to this point in the sacral promontory. But when you apply the compression using a closed fist or the heel of the hand, it will actually cause a stoppage of bleeding from the uterus. And when you compress it a little higher, that is just below the renal arteries, that's much better because it will minimize the collateral flow from the ovarian and inferior mesenteric arteries, which may not happen by doing it a little low at the bifurcation. Compression just above the bifurcation may be actually easier, but it's less effective, as I said, because of the extensive collateral blood supply to the uterus. The next procedure of compressing the aorta is the balloon occlusion using aortic catheter. It is positioned below the renal arteries and it will stop the bleeding for your ongoing resuscitation. It can be done either by a percutaneous femoral approach or by introducing the balloon catheter directly into the aorta because you're anyway opened up for a laparotomy. There's another procedure called as a resuscitative endovascular balloon occlusion of the aorta called RIBOVA. It's usually done in trauma, military or civilian settings or in emergency departments, where they place a percutaneous aortic balloon and it will actually stop the bleeding to the lower part of the body. In an appropriately equipped operating room, you can actually place it under ultrasound guidance or fluoroscopy if you've got a hybrid theater. The direct aortic approach is where you place the intra-aortic balloon catheters intraoperatively to stabilize the patients. And there's inserting a technique where you put a guide wire over which the balloon catheter is inserted. It is advanced up to the aorta, and the balloon is positioned below the renal arteries, and it's quite effective in stopping the collateral blood flow also. This position should ensure the substantial reduction in uterine blood flow while you're starting your surgical technique to manage the bleeding. As discussed above for the manual compression, placing the intra-aortic balloon at a lower level at just above the aortic bifurcation may not be as effective as doing it a little higher below the renal arteries because of the extensive collateral blood supply to the uterus. Then one thing which is very, very effective for a temporizing procedure before you start surgery is the non-pneumatic anti-shock garment. It's a first aid device and that reverses hypovolemic shock and decreases the obstetric hemorrhage. It consists of articulated neoprene segments that close tightly with Velcro. It will shunt the blood from the lower body to the co-organs. It will elevate the blood pressure and it will increase the preload and the cardiac output. And it's quite effective for you to manage a patient while she's being shifted or she's unstable. Suppose the patient is not at imminent risk of exsanguination, you can actually stop the uterine blood flow, and that's quite effective if the patient is not hemodynamically unstable. And you can do it with the uterine tourniquet, or you can ligate the uterine artery and the ovarian arteries, or you can clamp across uterine ligaments, or you can put a pelvic pack. It's quite comfortable for patients who are not at imminent risk of exsanguination. Uterine tourniquet is done with a Penrose drain or a urinary catheter. It's placed as low as possible around the lower uterine segment, but you should not incorporate the bladder. And then the two ends of the drain or the catheter are pulled in opposite directions, and they are closed as tightly as possible around the corpus to mechanically occlude the vascular supply. The next is the ligation of the uterine artery and the uterovarian arteries. That will reduce the perfusion pressure in the myometrium. It may not completely help in uterine atonia placenta preta, but at least it will decrease the blood flow while you're doing your other interventions. It actually does not harm the uterus and does not appear to impact reproductive function. The next is you put a large clamp across the uterovarian ligaments without ligating it. But when you put a clamp, to remember you're going to clamp the fallopian tubes also, and that may cause a problem with future conceptions, and she may need IVF because the tubes are occluded when you're putting a clamp across. And when you put this clamp across, it will stop the collateral blood flow from the ovarian arteries also. It may not be very helpful in uterine atonia placenta preta spectrum, but it will decrease the blood flow while you're attempting your other interventions. The next which is very good is pelvic packing. It will create a tamponade pressure which will exceed the arterial pressure and can control the bleeding from even small pelvic arteries. It can be used as a temporary measure in the management of broad ligament hematomas or petopetal hematomas while you are planning your surgical treatment. Lacerations that are difficult to repair because of the location of fibrous tissue can be stopped with the pelvic pack. And a bleeding which is related to coagulopathy, while you're replacing the coagulation factors, that bleeding can also be stopped with the pelvic pack, and it's quite useful when there's a post-hysterectomy bleeding. The other procedure of internal iliac artery ligation is technically challenging if there's a large uterus, and if you open the abdomen through a transverse low abdominal incision as in a cesarean, you'll have limited exposure. It's challenging when there's an ongoing pelvic hemorrhage because it's very difficult to identify the internal iliac artery. Suppose the patient's very obese, that also adds on to the difficulty. And it's not useful when there are extensive collateral vessels such as in placenta percreta. And remember, there's a reverse filling of the internal iliac artery which can occur beyond the point of ligation via the branch of the external iliac artery. There's the inferior epigastric, the obturatus, the deep circumflex iliac, and superior gluteal arteries. But it can reduce the pulse pressure of blood flowing to the uterus. It will be a temporary measure, so, but you have to be very careful when you're doing the internal iliac artery ligation. And always remember to know about the additional treatment is needed when you're doing a surgical management, because cessation of any severe hemorrhage will depend on the reversal of coagulopathy that has happened because of the excessive bleeding. So any factor which is contributing to an additional problem should be always reversed, and that will be you should not allow the patient to go into hypothermia. She should not go into acidosis, and she should not have a lack of clotting factors. You have to replace it as fast as possible. And even if the bleeding cannot be completely controlled initially, as long as you transfuse blood and blood products adequately, the hemodynamic stability can be achieved and you can maintain it. And suppose there are myometrial lacerations, it will cause a serious hemorrhage from the uterine incision, and that usually happens when there's lateral extension of the incision. And the bleeding from a hysterotomy or cesarean incision can be generally controlled by a suture ligation. You can identify the bleeding source and then you can suture it. But remember that the angles of a transverse incision should be always clearly visualized to ensure that you're not missing out on any retracted vessels which may be causing a bleeding into the broad ligament or retroperitoneum, and they need to be completely ligated. And for that, you need to extravase the uterus with gentle traction to adequately visualize the lateral areas of the uterus above and below the edges of the incision before you go and suture the bleeding vessel. Broad ligament hematomas can be very troublesome, and it's usually manifest as an enlarging hematoma beyond the end of the incision or a laceration, and it always suggests a retracted blood vessel with ongoing bleeding. And because it's very close to the ureter, when you have a broad ligament hematoma, you have to place your sutures laterally to control the bleeding with extreme caution, because the retracted vessel may be somewhere near the ureter. And once you take those sutures, after that you have to identify the ureter, and you have to see the integrity of both the ureters before you close the abdomen. And when there's a laceration of the uterine artery itself, or there is a laceration of the utero-ovarian artery branches, bilateral ligation of the uterine arteries, that's called the O'Leary stitch, is done, and it's actually very well. It's very helpful in many patients actually. It's preferable to internal iliac artery ligation because the uterine arteries are more readily accessible. The procedure is technically easier and has less risk to major adjacent vessels in the ureters, because you take it quite close to the uterus and you engulf the myometrium a little part, so that you engulf all the branches of the uterine artery when you're taking that stitch. And how do you do it is you take a 1-0 vicryl and you place it through the lateral aspect of the lower uterine segment as close to the cervix as possible. And then you take it through the broad ligament just lateral to the uterine vessels. So you take the uterine artery along with the little bit of the myometrium. And if this does not control bleeding, then you can take the vessels, the utero-ovarian arcade, and they are also similarly ligated, just distal to the conva by passing a suture through the myometrium. In this O'Leary stitch, you always take it a little bit through the myometrium also, so that you take all the vessels which will be contributing to the bleeding. And suppose there's a retroperitoneal bleeding, identification of an isolated bleeding point in the retroperitoneum is quite impossible in many cases. And it's not advisable to open the retroperitoneum, attempt a dissection of any non-expanding hematoma. If it's not expanding, you can actually watch for some time, and usually sometimes it can subside. But if you're having a hematoma in a patient who's coagulopathic and is hemodynamically unstable, it's quite difficult if you do not go for temporary measures to stabilize the patient before beginning the retroperitoneal surgery. So any bleeding in the retroperitoneal area, you will have to stabilize the patient, correct her coagulopathy before you start. Otherwise, it could be very, very difficult. And you can use topical hemostatic agents in retroperitoneal bleeding, which sometimes can control mild diffuse bleeding from peritoneal surfaces. But if you identify a discrete retroperitoneal vessel which is responsible for the hemorrhage, it should be clamped and ligated with an appropriate suture material. But bleeding adjacent to the uterus without clear bleeding points can be managed by the ligation of uterine vessels, that is the O'Leary stitch. If if you're unable to control the bleeding with the identification of the bleeding points, and you think it's going to be a retracted vessel, you can attempt an ipsilateral internal ligation where the retroperitoneal bleeding is happening. And if that also does, for that also if there's no response, you may need to go for bilateral internal cardiac ligation and or pelvic packing, which whichever you think will be effective. But given the technical difficulties of safely ligating the internal arteries, especially when there's a setting of DIC and ongoing bleeding, please remember to call the senior most surgeons who has got experience in the procedure, and only when adequate blood products and facilities are available when you attempt a management of retroperitoneal bleeding, which is not being managed with conventional measures. And remember that when there's a less experience from the clinician, it's better to go for key temporary measures rather than the heroic treatments which you read up in books. And the key measures which can help you to stop the bleeding is just a pressure over the bleeding point area, and the resuscitation and reversal of any coagulopathy, and calling for help from an experienced surgeon. That will take you a longer way in managing the PPH compared to going for heroic measures. And if the hospital has a capability of performing an arterial embolization in the operating room, that is, you have a hybrid theater that can be utilized, but do not remove a hemodynamically unstable patient from an operating theater to an interventional radiology suite, which will actually aggravate the problem. And hysterectomy is a definitive treatment of uterine bleeding. Regardless of whatever the etiology of PPH, a continued blood loss can lead to severe coagulopathy because of the massive loss of coagulation factors. And that can lead on to severe hypolemia, tissue hypoxia, hypothermia, electrolyte abnormalities, and acidosis, which will further compromise a patient's status. So suppose a patient is not already at laparotomy and has developed the above complications, then correction of the severe physiological defects before hysterectomy, if possible, could be life-saving. So suppose you have any additional complication before you're taking the patient hysterectomy, correct them before you take for hysterectomy. Do not think that hysterectomy will help you out the maximum. It's not going to be that. You have to correct everything before you start your procedure for hysterectomy. And remember to go for early hysterectomy in these conditions of placenta accreta, spectrum, and uterine rupture. Do not procrastinate. And there are certain damage control approaches which can be done for persistent bleeding, which can happen in some cases even after hysterectomy. And for that, you have to put a large bore drain in the pelvis when you're suspecting that she's going to have an ongoing DIC. And you can also put a pelvic pack after hysterectomy to prevent further bleeding. Those will be preventive measures to prevent bleeding after hysterectomy. Pelvic packing is done with an umbrella pack. You fill a sterile plastic bag or a cloth container with gauze. And if you put wet gauze, it will add more weight and place it against the pelvic bleeders. You put drawstrings to the pack and they pull through the vagina, and they attach to a weight which will provide traction as the pack exerts pressure against the pelvic floor. And a pelvic tamponing device also can be used similarly as a pelvic pressure pack after hysterectomy for PPH. And you can apply hemostatic agents to the bleeding tissue, and they can be included in pads for the pelvic tamponade. Something called a negative pressure vacuum device, which can be used to continually collect fluid from the wound and abdominal cavity like a drain without damaging the viscera, because here there will be a protective layer which is placed between the viscera and the device. They can be applied to the dressing after the surgical team packs, covers, and seals the open abdomen. But there's actually no study in persistent bleeding of the hysterectomy or PPH with negative pressure vacuum devices, but it has been extensively used on surgical and trauma patients, and it has been associated with the improved 30-day survival and higher rates of 30-day primary facial closure. So you can attempt it if you have it. Post-surgical management for patients with PPH, they should remain in the operating room with continuous monitoring, with the replacement of appropriate blood products and correction of physiological derangements. Temporary facial closure is usually better because you may need to go and open her up again. This approach halts a downward spiral and lessens the risk of abdominal compartment syndrome. Is more likely if the fascia is closed. And abdominal compartment syndrome is very difficult to define postpartum since post-cesarean intraabdominal pressure appears to be higher than in the general surgical population, especially if she's of a higher body mass index and she's got a hypertensive disorder. So regarding the step down after you manage a patient with PPH, it depends on the degree of blood loss and the amount of resuscitation which is required to manage her, and the risk of resumption of bleeding and the need for ventilation. They can be transferred to either a high care post anesthesia care unit or an intensive care unit, and she needs in one-to-one nursing and close observation of the physician team as appropriate. And you have to remember that it is in a continuous bleeding if you are using more than 2 units of packed cells per hour for 3 hours, and that thing signifying that she's got severe ongoing bleeding. Then she may be returned to the operating room, or an arterial embolization by an interventional vascular specialist may be needed for her. And when should you remove a pelvic pack? It should be removed after 48 hours, cannot be removed too soon because the bleeding may resume, but do not remove too late, and then pelvic infection or abscess may occur. And you have to remove it under general anesthesia. The wound is open and the gauze is removed with gentle traction. And after this, the pelvis is irrigated with saline to clear the loose clots and other debris. But do not aggressively explore the pelvis if there's no pooling of blood. And the wound is then reapproximated in the usual manner. The role of embolization in PPHs can be considered when there's a persistent non-life-threatening deep pelvic bleeding, which can occur after repair of lacerations or and that when they are not controlled by surgical ligation or ablation. It is an option if the facility has got an appropriately equipped operating room. That is, a hybrid theater is there, and you've got a C-arm and a carbon fiber table. Then you can do it in the theater itself. After laparotomy, when there's a persistent slow internal bleeding in a hemodynamically stable patient, you can consider transferring her to an interventional radiologist suite. But remember, do not transfer hemodynamically unstable patients to a radiology unit. And you can attempt an embolization after failed surgical arterial ligation. And hemodynamically unstable patients should be always evaluated in the operating room and not in the interventional radiology suite. But if the facility has got a hybrid theater, you can attempt it in the theater itself. And laparotomy is performed after an embolization if the patient is deteriorating. Do not think that embolization will help all the patients. And embolization can be attempted in a placenta accreta spectrum. And there you can do a direct arterial puncture of the internal iliac artery and embolize at cesarean birth. And it's quite useful in all the cases, and they found no complications like fever, buttock pain, or acute limb ischemia when a direct arterial puncture for embolization was attempted inside the theater. So the take-home messages for this talk will be: if pharmacological measures fail to control the hemorrhage, go on to surgical interventions sooner rather than later. Intrauterine balloon tamponade will be the first surgical intervention where uterine atony is the cause. Conservative surgical interventions may be attempted as a second line. Compression sutures and stepwise uterine revascularization will be your first line surgical procedures after tamponade. But if she's hemodynamically unstable, do a aortic compression technique before you go for definitive surgery. Suppose she's hemodynamically stable, then you can go for uterine compression sutures, and always resort to hysterectomy sooner rather than later, especially in case of placenta accreta or uterine rupture. Thank you so much for the patient hearing. Thank you, Monica, for the opportunity.
Thank you, ma'am. Thank you so much.
Can you stop playing the video? Yeah. Pratibha, can you give the concluding remarks?
It's a stop.
Yes, thank you so much. That video was very awesome, and it had very enlightening points. It has cleared that we can manage PPH. If managed in time, it can be very life-saving. So it was indeed a very insightful CME today on PIH, preeclampsia, and surgical management of PPH. I thank all the dignitaries, Chairperson of PSC Committee, Dr. Monica Umbardan, Dr. Rashmi Kahar Madam, Dr. Girija Wag Madam, and Dr. Charmila Ayu Madam for their enlightening talks. Also the guest of honor and Dr. Sujata Dalvi Madam, Dr. Rajendra Singh Pardesi sir for being there and giving their blessings. Thank you so much. We conclude this. Dr. Monica,
I would like to add thank you to the technical team at Walter Bush
Yes,
for
Walter
giving
Bush.
us an opportunity
you, ma'am.
for this.
Heroes have been amazing there. They have been managing it the whole time. Thank you so much.
Yeah. Thank you, everyone. Thank you,
Thank you,
Pratibha.
ma'am.
Yes, bye.
Thank you, ma'am. Walter Bushnell is always ready to provide technical support such kind of feast. So,
Thank you.
ma'am, with your permission, can I stop this webinar?
Yeah, we can stop the recording and
Should I stop?
the webinar. Yeah.